Good afternoon, everyone. Those who don't know, I'm Dr. Eranga Ganewatte at Ridgway Hospital in Colombo. And first of all, let me thank for your kind invitation from UA Clinical Society, and special thanks to Dr. UDC Chandana for your kind invitation. So I know it's after the lunch, but I'll try and run through some of the interesting topics in the field of interventional radiology. Hopefully it will keep you up. And basically interventional radiology is using different techniques of imaging modalities to guide our therapy and target precise treatment of therapy to the particular organ. And what are the basic skills that an interventional radiologist are required is to use the available imaging modalities into manipulate your needles and the use of catheters to navigate under image control. And the current practice interventional radiologist plays a very important role in patient management. There are two broad categories. The first one is the vascular, and then you have another arm, non-vascular, and into vascular you have arterial, venous, and lymphatic interventions. Briefly looking at some of the non-vascular interventions, as you all know, there are a lot of non-vascular interventions which are done all over the country by a lot of radiologists, which are also image guided. But in an intervention radiology, you are to do more difficult location biopsies, especially called para-aortic, mesenteric, OMENTAL, vertebral, or deep-seated pelvic interventions. Here a small example that we did a couple of years ago. It's a para-aortic lymph nodes. If you can see it here on the right side, and you can see that the right ureter right behind the lesion. So we had to do a contrast CT beforehand so that we can opacify the ureter and then use the image guidance to CT guidance to locate the lesion and take a good sample of it. And we should be very careful not to damage the ureter on the way to access the lesion. And here is another case that interesting one with the OMENTAL thickening. Surgeon didn't want to go and take a sample as it was not very sure of what to do, and the patient condition was. So what we had to do is we went in and anchored the momentum to the abdominal wall with another needle and take another sample from the coaxial needle and take samples, and it went out very well for the diagnostic purposes. And just to update on vertebral biopsies and vertebral interventions, if you have a destructive lesion like this, you can easily go through it with the available true cut needles, because the bones are very fragile and you will get into the diseased bone and take a good sample of it. In the case of not that difficult diseased bone, then you need to have a bone cutting needles to get the access, and always use the image guidance to precisely target the needle tip to take a adequate sampling. And here's another case that post-surgically patient had a small collection in the presacral space. Surgeon didn't want to go and take out anything, so then you have to manipulate and think out of the box and turn the patient into a different location or the positioning of the so that we can have a safe access, and to using a guide wire and a catheter we would be able to drain this collection. And in nowadays the whole treatment modalities of the tumors, it's MDTs, and all the time the physician, the diagnostic radiologist, interventional radiologist, pathologist, oncologist are all involved in patient management. And earlier it was only 3 pillars. Now the interventional oncology and interventional radiology has come into play, and there are 4 pillars in tumor management now. What are the things that we can ablate percutaneously? We can do liver, kidney, lung, bone, or thyroid lesions. And in the available options when you take for therapeutic options for tumor ablation, there are so many techniques available at hand at the moment. Most frequently used was the radiofrequency ablation, which is the earliest modality that we had at our hand. And then it comes to microwave ablation, laser, cryoablation, IRE or radiogenic ablation, and then high intensity focus ultrasound, HIFU, and chemical ablation. Most of our available except for few things called IRE or the HIFU are not available in Sri Lanka, but rest of the treatment modalities are available at our hand these days. So I'll just briefly touch on some of the treatment of HCC, which is a mainstay of interventional radiologist therapeutic arm. Thermal ablations are indicated in hepatocellular carcinoma, which are less than 3 or but we tend to go up to 4 centimeters now, since the microwave ablation, which can go up to 4 centimeters with a 1 centimeter periphery of normal tissue, and it should be combined with embolization, and the tissue loss reduced compared to the resection, and incomplete ablation or local recurrence increases, and RFA is best evaluated, followed by microwave, and the systemic effect of ablations are well under investigation, and patient had tolerated these lesions very well. So percutaneous treatment techniques, it can be done in outpatient basis, but usually we prefer to do it on inpatient. It can be percutaneous, intraoperative, laparoscopic. Procedure take 1 to 2 hours maximum, and we use ultrasound, CT or MR guidance, conscious sedation plus local anesthesia, or maybe at times we might use even general anesthesia when the location is not that easy accessible and the patient cooperation is necessary. And it can be monopolar or bipolar, and procedure observation is about 4 to 6 hours post-procedure. So just to brief, what are the things that we have? This is RFA on the top row, and usually we have a multi-stein system where you have to go into the lesion and open up the stein and take up the lesion according to the size of the lesion. And on the other hand, the microwave is different technique. You don't need a foot paddle, and then you can target lesion right up to the lesion, and depending on the size of the lesion, you can vary your temperature. Once you enter nice places in the lesion, you can decide on what type of heat that you need to ablate depending on the size of the lesion. So there are 2 brief basic differences in microwave and RFA. I won't go into details as it's beyond this lecture. And so when you take off peripheral HCC, ablation versus resection, when it comes to peripheral lesion, the ablation and the resection is almost the same, because almost you take peripheral resection, you can do non-anatomical resection. So the volume of liver tissue loss would be almost equal as for ablation. But when it comes to central lesions, whereas you just take out lesion plus 1 centimeter, but if you do a resection, it will be at least a segmentectomy or lobectomy of that lesion. So you are saving a lot of liver tissue, whereas if you talk about cirrhosis, where the liver always has compromised with reduced liver functions. And there is always talk in the horizon where you can use combined therapy, TACE or TAC, with thermal ablation and systemic treatment plus ablation, which have all shown good responses. And the only problem would be the time and time availability and the resources in a country like us. But they have all shown that when you do RFA with combined therapy, the results are much, much higher compared to the just single arm of therapy. Few examples of hematoma ablation. This is a very nice lesion seen on ultrasound, confirmed with CT, and this is needle placement, and you confirm with CT. And this is the post-ablation imaging. You can see very nicely there's no more arterial enhancement, and you might even see this little bit of hyperemia around post-ablation, which is quite common. But if you don't see a nodular enhancement after ablation, that is quite satisfactory following RFA ablation. And this is another lesion where you can see that the lesion is almost touching the abdominal wall, and using a multi-sign RFA would be a tricky situation, as it would always go one stein into the abdominal wall, which can burn and be a lot of pain for the patient. But if you use microwave in this location, it's quite safe, and you can see nicely the tumor has been ablated. And this is post-ablation follow-up, and you can still see there's no residual enhancement following ablation. Ablation can be at times be tricky depending on the location, if you are touching the extra. And this is a very interesting location for ablation, and as you can see that the right coronary goes right just above the lesion, and you can safely ablate these lesions depending on the size of the lesion. And my friend Chintaka has published even a paper on this, which he did during his overseas training in US, Singapore. And similar cases, which we can see that there are almost juxtacardiac locations, but using a microwave, you can be safely ablated, and you need to use always MR or CT guidance during the procedure. This is another case touching the diaphragm. You can see that the lesion is, and there were no post-procedure cases. A similar case that we did in Colombo, and you can see that this lesion is always touching the pericardium, and it was completely followed up, and there were no recurrence following 3 months follow-up period. Moving on to transarterial chemoembolization for HCC. You all know that when the lesion size is more than 4 centimeters, always you are encouraged to treat with transarterial chemoembolization. And depending on the treatment options, what we basically do, we get the access through the femoral or brachial access, then you access through the celiac axis and go right into the tumor, and then you infuse embolization, that is doxorubicin and lipidol, and then you block off the feeding artery, which will result in shrinking of the tumor. And mind you, this is not a therapeutic procedure, though it's therapeutic, it's not a complete ablation. So you need to follow up these carefully, because there can be recurrence as time progresses. And this is just to show some of the images that you can see. There are multiple feeders of these ones. The trick of this treatment, when you have the multiple feeders, is to select one good predominant branch and go right into the lesion and inject. Then there is always reflux into the other branches, which will ultimately be knocked off by itself with the lipidol cast. And you can see that after the ablation, the embolization, the lipidol cast is within the lesion. It's very nicely seen. And this is follow-up CT. You can see that the density of the lesion is very good with the lipidol cast, and there is no residual enhancement surrounding it. And another biliary intervention would be a TIPS procedure for intractable. There are certain indications for TIPS procedure, especially patients who are awaiting liver transplant would be beneficial from this, and patient who has intractable ascites or repeated variceal bleeding which are uncontrollable, and especially patients who are awaiting liver transplant are really benefited on these locations. You need to create a pathway between the hepatic vein and the portal vein. Once you get the access, you need to dilate with the balloon, and then you plant a semi-covered stent across it, and once you do it, you can see that the flow is really nicely going into the bypassing the liver into the hepatic vein. Another liver intervention would be the portal vein embolization. This is a case of where you need to embolize one branch of the portal vein in order to hypertrophy the other prior to surgery, especially if you are going for a extended hepatic or right hepatic or extended left hepatic artery, when you need where the future liver remnant is not adequate enough for survival, then you need to go in and access the portal vein and embolize. You can do it ipsilateral or contralateral. It's always preferred to do ipsilateral because then the damaged part will be anyway removed. So the contralateral portal veins are preserved and no damage has been done. And again, another hepatobiliary intervention would be splenic artery embolization, where the patients are having hypersplenism and with pancytopenia, not responding to treatment. Then you might need to do embolization. We tend to do partial embolization because if you do a complete embolization, then the whole spleen will be necrosed and you will end up in having a large abscess. So we tend to generally do partial embolization so that the liver splenic volume will be reduced to a certain extent to reduce the pancytopenic effect of that patient. Again, it's a vascular procedure. You get through the femoral or brachial access, then you access to the splenic artery. Sometimes you tend to block it proximally so that the distal left gastric artery take over and there won't be complete necrosis of the spleen. But sometimes you can go into this one of these branches and knock off half of it, leaving the other half alive, which will be also benefit for the patient. Another hepatobiliary intervention is commonly coming is where you have CBD or obstruction. Then if you can't get a endoscopic or ERCP via and stenting, then you will be asked to do some at least external biliary drainage, which can be done on easily on ultrasound. But I would recommend to do it using fluoroscopic guidance as well. So then you know where you are going. The wires can be monitored easily. It can be used as a temporary measure for the external biliary drainage, just to bring up the bilirubin levels and bring down the, in fact, to bring down the bilirubin and settle the patient. Then you can later on and go and do the stenting. So this is internal biliary drainage through access of the right hepatic artery for a distal CBD obstruction. Then some of the other non-vascular interventions would be pain related, where you can use different techniques and different methods to use and neutralize the especially these pancreatitis patients where you have intractable pain. Then you can use neurolysis using alcohol and ablate the celiac ganglion, so the patient have a relatively pain-free normal life after this. But you need to do sometimes need to do repeated procedures depending on his level of pain. But patient will be very happy once you do it, and they will feel the relief of pain on table itself. So moving on to some of the interventions in the head and neck. This is a patient of known nasopharyngeal carcinoma. You can see that there's a lesion on the right side of the neck, and which was ultimately eroding into the common carotid, and you can see there's a pseudoaneurysm, and this is a carotid blowout syndrome, which is life-threatening. And then you go ahead and put a covered stent across it, saving the life of the patient. This is some of the areas where you have very vascular tumors in the head and neck, especially the glomus tumors in the head and neck region. These are very vascular, and always the ENT surgeons will be asking to go ahead and pre-embolize before the surgery, so the blood loss will be less, and it will be very easy for the surgeons to go and take it off. Otherwise, will be a lot of blood in the surgical field. It will obscure in the surgical field, and you will be always come out leaving a part of the lesion behind. Another very hypervascular neck and head region tumor, the juvenile angiofibromas seen in young male patients, and you can see obscuring the nasopharynx, and it's very vascular. You can see the contrast enhancement, and you go it, and usually you get an external carotid supply, and you can go ahead and embolize before the surgery, usually 48 to 72 hours prior to the procedure. So you'll have the surgeons have a much easier life when you're operating. And just very interesting chemotherapy for young children for retinoblastoma. There are usually catheter-directed therapies, not very difficult. Get to a patient to a cath lab and get the access to the ophthalmic artery, and you can inject the chemo directly into the ophthalmic artery, and depending on your ophthalmologist requirements and the ophthalmologist plus the oncologist dose decided by them, and they can do in multiple sessions if needed, and shown very good results all over the world. And this is one of the cases that we can show that is gone into the ophthalmic artery, injecting the chemotherapy into the ophthalmic artery. Moving on to very interesting and developing aspect of interventional radiology, acute cerebral stroke management, but it's well established all over the world. When the patient present to a ETU, to a non-contrast CT, and then you assess the patient for aspect score, and if it is less than 7 or more, you can go ahead and do thrombectomy. And this is a MRA. You can see that aspect score, it's well documented, it's very easy. Out of 10, if you have more than 7, then you are that the infarcted area is not big enough. So if you do an intervention, you can save a lot of brain tissues, and a lot of disability can be saved. So what you can, there are certain few ways of doing it, but basically what we do is you do a non-contrast CT on presentation, and ideally we would have done a CT cerebral angiogram, locate where the thrombus is. Then we put a guide catheter, and through that we can put a small wire through the lesion, and then you cross it through the thrombus and expand a stent across it and let it settle for a while, and then you drag everything out, and most of the time you can take out the clot completely, and improving the circulation and saving a lot of brain tissues and disability for the patient. This is basically a biplanar cath lab, which is available in Sri Lanka and available in North as well. And these are needed for cerebral interventions, especially the AVMs, but rest of the things, I think just a monoplanar DSA would be more than enough to do those procedures. So this is one of the cases that you can see. There's a right MCA block, complete knockoff, do a DSA, you can still see that. And then you can see that once you do the thrombectomy, there's resolution of the thrombus, and opacification of the M1 and M2 branches on the right side. Again, another case, you can see that pre-thrombectomy, there's complete obstruction of the M1 and then M1 and A1. And once you do that, there is complete resolution of the vascularity into the brain. Another case, M1 occlusion, post-thrombectomy, very good, TICI3 recanalization. Moving on to cerebral coiling, which is well-known techniques to treat aneurysms. If you have a narrow neck aneurysm, you can always put a catheter, then you put a 3D coil to secure the neck, and then you can fill it up with further coils to fill up the aneurysm. Here, one of the cases, you can see that in the CT angiogram, there's an ACOM aneurysm, bilobe, fairly big, but relatively narrow neck. And then you put a wire, you put a balloon across the opening. If you have a slightly larger balloon, then you can embolize with the coils and to secure the aneurysm, and the post-embolization has shown that it's completely excluded from the circulation. And this is after a post-embolization. X-ray shows of the coil sitting on the aneurysm. Moving on to cerebral AVM embolization. This is a patient who had a AVM on the right parietal region. You can see very large nidus with large draining veins and draining into the cortical veins. Then what you do, you just go in and start injecting onyx, that is a liquid embolic material, right up to the nidus. You have to go up to the nidus. If you do it proximally, the other feeders will be left behind and there won't be any treatment for the AVM. Just you are blocking the feeding arteries, and then later on you won't have any access to the AVM, and they won't be able to treat it. And you can see that the complete AVM exclusion from the circulation. Complete exclusion of the AVM from the circulation. And this is post-embolization, the onyx cast. You can see it on X-rays, and then you need to follow up with MR to see whether there's any further developments. Another interesting topic would be venous sampling for endocrine pathologies, which is very well documented and accepted methods of diagnosis. When you can't diagnose it on imaging alone, you need to get samples to confirm that the real pathology is in that region. So basically what you do, you do adrenal vein, inferior petrosal, arteriovenous stimulating samples for pancreatic insulinomas, and parathyroid sampling. So this is what you call arterial stimulated venous sampling, ASVS. You need to get a catheter into the hepatic vein to take the samples. You go into different arteries supplying the pancreas, gastroduodenal, pancreatic, superior gastric, those arteries, and the hepatic artery. Inject glucagon and stimulate the pancreas to produce insulin. Take the samples at intervals, and you can basically analyze and say which part of the pancreas is abnormal. And here you see there is twofold increase on the distal splenic artery, means that the lesion is located in the distal part of the pancreas. And they went in and we did an ultrasound, easily could see that the hypervascular lesion which was in the tail of the pancreas, and it was removed and patient recovered completely. And this is where you can do interferopeteral sampling for hormone assays in ACTH, or even for any insulin, not really the pituitary hormones, but you need to do it on both sides. You can see this is the inferior petrous sinus going across the cavernous sinus and draining into the other side, just to make. And then you need to take a small microcatheter up to the inferior petrosal sinus, take samples. Ideally, you should do it simultaneously, but if you do it little later also, it doesn't really matter. But if you do a ACTH stimulator, then you have to do a simultaneous sampling from both sides. This is parathyroid venous sampling. Looks very easy, but you need to take about 18 samples to have a proper parathyroid sampling to locate the parathyroid tumor. And this is it, how it comes from, and this is how the results comes. And you can see there's a high values in inferior thyroid artery vein, indicating that the supply is from the right side inferiorly. And this is adrenal venous sampling, which when you have to, because some of the lesions, if you have adenomas, most of the lesions are non-secretory. To see when you have the Cushing syndrome, then you have to need to venous sampling to locate before going and resecting. And that's basically just overview of what we do as interventional radiologists. And if you have any questions, I'm more than happy to answer, and hope that you my talk would just run through some of the interesting things that interventional radiology can do these days. Thank you very much, and thank you very much again for inviting me. Thank you.